Welcome to our third and last video on localizing neurologic lesions. Let's begin. Here are the points we're going to discuss in our lecture. We will address the lesions of the spinal cord, peripheral neurons, neuromuscular junction, and muscles. Lastly, we will finish up with diagnosis and management of neurologic lesions. Let's move on to the spinal cord lesions. These can be caused by infarction, trauma, infection, and neoplasms. Importantly, the patient presents with ipsilateral motor deficits of upper motor neuron type below the level of lesion. On the other hand, there are ipsilateral motor deficits of lower motor neuron type at the level of lesion. This results from injury of anterior horn cells at the lesion level. Remember that the anterior horn cell is the second-order neuron in the corticospinal tract. Thus, injury of cell body here results in deficits of lower motor neuron type. Also, a characteristic feature of spinal cord lesions is the presence of sensory level that is detected on physical exam. Sensory level is the lowest dermatome with intact pinprick and light touch sensation. Here's a table presenting some of the classic syndromes that are caused by spinal cord lesions. They're very good examples of what we presented in the previous slide, so let's make sure we discuss them briefly. First, anterior cord syndrome usually results from occlusion of anterior spinal artery. Let's take a look at a cross-section of spinal cord in the next slide. In this transverse section of spinal cord, please note that anterior cord syndrome affects this region. It involves disruption of the spinothalamic tracts, the corticospinal tracts, and the anterior horn cells on both sides. Let's get back to our table. The anterior cord syndrome manifests with bilateral hemiparesis at and below lesion level due to injury of corticospinal tracts and anterior horn cells. Also, there is bilateral loss of pain and temperature sensation below the lesion level due to injury of spinothalamic tracts. Second, we have in our table the central cord syndrome. It is commonly seen in conditions like syringomyelia. Let's take another look at the cross-section of spinal cord. In this transverse section, please note that central cord syndrome affects this region. It involves disruption of anterior white commissure of spinothalamic fibers, as well as anterior horn cells at the lesion level. The patient having central cord syndrome presents with bilateral loss of pain and temperature sensation at the lesion level due to injury of anterior white commissure of spinothalamic fibers. Also, motor deficits of LMN-type at the level of lesion result from injury of anterior horn cells. Finally, we have Brown-Séquard syndrome. This is caused by hemisection of the spinal cord. Let's get back to the cross-section in the next slide. In this transverse section, please note that Brown-Séquard syndrome affects this region. It involves the spinothalamic tract, corticospinal tract, dorsal column, anterior horn cell, as well as the cervical sympathetic pathway in some cases. The patient with Brown-Séquard syndrome presents with ipsilateral hemiparesis at and below the lesion level due to injury of corticospinal tract and anterior horn cell. There is contralateral loss of pain and temperature sensation below the lesion level due to disruption of spinothalamic tract. Also, there is ipsilateral loss of proprioception and vibratory sense at and below the lesion level because the dorsal column is affected. Finally, ipsilateral Horner syndrome may result if there is disruption of cervical sympathetic pathway. Let's try a question. A 59-year-old man presents to the office due to recent onset of weakness. Physical exam reveals flaccidity in the upper extremity muscles and spasticity in the lower extremity muscles. The patient cannot feel the pain and temperature below the lower neck. Proprioception and vibratory sensation are intact throughout the body. What is the most likely diagnosis? The patient has flaccidity in the upper extremity muscles and spasticity in the lower extremity muscles. This pattern of weakness is consistent with the type of LMN deficit at the level of spinal cord lesion and the type of UMN deficit below the level of the lesion due to injury of anterior horn cells and corticospinal tracts, respectively. Additionally, the patient cannot feel the pain and temperature below the lower neck, which indicate damage of the spinothalamic tracts. Finally, proprioception and vibratory sensation are intact throughout the body, which means that the dorsal columns of the spinal cord are spared. Damage to all the tracts of the spinal cord except for the dorsal columns is consistent with the anterior cord syndrome. Now let's move on to peripheral nerve lesions. These can be caused by trauma, compression, diabetes mellitus, lead poisoning, and chemotherapy, particularly vincristine. These are all high-yield causes that are frequently tested. The peripheral neuropathy can be classified into motor neuropathy and sensory neuropathy. In the motor neuropathy, symptoms depend on the affected myotomes. Generally speaking, weakness of LMN type is seen, as well as absent or diminished deep tendon reflexes on physical exam. On the other hand, symptoms of sensory neuropathy depend on the affected dermatomes. In general, there is paresthesia, loss of pain and temperature sensation, as well as impaired proprioception and vibratory sensation. Let's move on to neuromuscular junction lesions. These can importantly be seen in myasthenia gravis and Lambert-Eaton myasthenic syndromes. Typically, in NMJ lesions, there is muscle weakness and fatigability. However, there is no muscle atrophy and sensation is intact. Let's finally move on to muscle lesions, also known as myopathy. The causes involve hereditary conditions such as Duchenne muscular dystrophy, autoimmune disease such as polymyositis, as well as the use of corticosteroids. These conditions are characterized by symmetric muscle weakness that is often proximal. Also, similar to NMJ lesions, sensations remain intact. Finally, muscle atrophy and diminished deep tendon reflexes can be seen in later course of the disease. How can myasthenia gravis and Lambert-Eaton myasthenic syndrome be differentiated from one another? Before we answer this question, let's recall several high-yield concepts. Myasthenia gravis is caused by antibodies to the nicotinic acetylcholine receptors on the motor end plate. In contrast, the Lambert-Eaton myasthenic syndrome is caused by antibodies to the presynaptic calcium channels. Let's compare and contrast these two conditions. Myasthenia gravis is characterized by decremental muscle response on the electromyography. It means that muscle contraction weakens after every single nerve depolarization. This is because successive nerve depolarizations deplete acetylcholine in the presynaptic terminals. Therefore, low levels of acetylcholine can no longer displace the antibodies on the motor end plates. In contrast, Lambert-Eaton myasthenic syndrome is characterized by incremental muscle response on the electromyography. It means that muscle contraction strengthens after every single nerve depolarization. This is because successive nerve depolarizations cause accumulation of sufficient calcium in the presynaptic terminals. Therefore, presynaptic terminals start releasing acetylcholine and the muscle contraction strengthens. Additionally, myasthenia gravis is characterized by weakness of small muscles such as extraocular muscles. This is because small muscles contract very frequently, so acetylcholine quickly gets depleted in the corresponding nerves. In contrast, Lambert-Eaton myasthenic syndrome is characterized by weakness of large muscles such as shoulder muscles. This is because large muscles do not contract frequently. Therefore, it takes time for the corresponding nerves to reach sufficient intracellular calcium levels in order to release acetylcholine. Finally, Lambert-Eaton myasthenic syndrome is also characterized by autonomic symptoms like dry mouth and erectile dysfunction. This is because the inability to release acetylcholine from the presynaptic terminals also affects the parasympathetic nerve fibers. We will briefly discuss the diagnosis and management now. The diagnosis of neurologic lesions can be achieved by different and various means. However, clinical examination is always essential. Imaging tests, such as CT and MRI, are often performed. Nerve conduction and electromyographic studies can also be helpful in some conditions. The management generally depends on treating the underlying cause. Let's try a question. A 38-year-old woman is brought to the emergency department due to severe burns on both hands. She is a chef and she burned her hands by accidentally spilling the hot oil. The patient did not feel any pain but called the ambulance due to severe swelling and redness. Her past medical history includes a motor vehicle accident 3 months ago. Physical exam reveals second-degree burns on dorsal surfaces of hands. Pain and temperature sensation is diminished in both upper extremities but is intact in the lower extremities. Physical exam also shows upper extremity weakness and 1+ biceps reflex bilaterally. Knee and ankle reflexes are normal. Which of the following is most likely the diagnosis? A. Anterior cord syndrome. B. Brown-Séquard syndrome. C. Central cord syndrome. Or D. Amyotrophic lateral sclerosis. This patient did not feel any pain while accidentally spilling the hot oil on her hands. Pain and temperature sensation is diminished in both upper extremities but is intact in the lower. Upper extremities reflexes are diminished, evidenced by a 1+ bicep reflex. However, the knee and ankle reflex are normal. Bilateral loss of pain and temperature sensation along with lower motor neuron signs at the level of lesion is consistent with central cord syndrome. The central cord syndrome likely developed as a result of spinal trauma after the motor vehicle accident 3 months ago. Therefore, the correct answer is option C. Here's a table comparing the key features of the anterior cord syndrome, central cord syndrome, and Brown-Séquard syndrome. Let's discuss why other options are incorrect. Option A is incorrect because anterior cord syndrome is characterized by bilateral loss of pain and temperature sensation, bilateral lower motor neuron weakness at the level of lesion, and bilateral upper motor neuron weakness below level of lesion. Option B is incorrect because Brown-Séquard syndrome is characterized by contralateral loss of pain and temperature sensation, ipsilateral lower motor neuron weakness at the level of lesion, and ipsilateral upper motor neuron weakness below the level of lesion. Finally, option D is incorrect because amyotrophic lateral sclerosis is characterized by bilateral lower motor neuron weakness at the level of the cord demyelination, and the bilateral upper motor neuron weakness below the level of demyelination. However, all sensations are normal in amyotrophic lateral sclerosis. And that concludes our lecture on the spinal cord, peripheral neurons, neuromuscular junction, and muscles.